Hello, my name is Stephen Kempton, Event Manager for the Arrhythmia Alliance, and I would like to welcome you to our Living With series. We hope that many of your questions will be answered as you listen to our world-renowned specialist. I'm honoured to welcome today Dr. Leon Taszczak from Harvard Medical School and the Cardiac Arrhythmia Service at Massachusetts General Hospital, who will be presenting on living with a pacemaker. Thank you, Leon, for joining us, and we look forward to hearing from you.
Stephen, thank you for inviting me to join you. It's a pleasure for me to be here. I'd like to spend the next few minutes with you and our audience talking about life with a pacemaker. My session has three objectives, and at the end of this session, my hope is that the audience will be able to, number one, better recognize the reasons for pacemaker implant. Number two, better understand the pacemaker implant procedure itself. And number three, better understand what to expect after pacemaker implant. So let's move on to the first objective. As you may know, the contraction of the chambers of the heart is actually the result of very carefully coordinated electrical signals, which initiate at the sinus node, which sits in the upper right corner of the heart, as shown here in this pictorial demonstration of the heart. This serves as the metronome of the heart, which creates a spontaneous electrical signal, which is then propagated to the upper chambers of the heart in a nearly simultaneous fashion. These signals coalesce at the crux of the heart and then travel through the ventricles, which also contract in a nearly simultaneous fashion. And it's the contraction of the ventricles that you sense as a pulse. These electrical events are manifest as the different waves that you may have seen in your doctor's office on an EKG. A number of different disturbances can occur in the heart's electrical system over time, leading to potentially slowed or blocked conduction. And this can occur anywhere within the heart's electrical conduction system. In most cases, this type of block is irreversible and can be due to age in a person who has no other heart disease, or in a person who has coronary artery disease, valve disease, or who has previously undergone cardiac surgery. The slowing of the heart rate may indeed be intermittent and not present at all times. And this is an EKG taken from a patient who is in a normal rhythm, which is a little bit on the slow side at baseline, but not creating any issues. And as we go across the tracing, we find that it gradually slows. And this is a tracing that was performed in a patient who was experiencing intermittent bouts of lightheadedness. And through the use of this non-invasive monitoring, we were able to determine that the patient's symptoms were correlated to periods of time during which the heart rate was slow. Now, unfortunately, there is no medication that we can give orally on a routine basis that'll restore disease in the heart's electrical conduction system. And the standard of care for those patients who have disturbances of the conduction system leading to abnormally slow heart rates involves implant of a pacemaker, which is an electronic device which effectively serves as an electrical bypass of your heart's native conduction system. And the indications for pacemaker implant are very well validated by established guidelines world over. So now that we've talked a bit about the reasons for a pacemaker implant, I'd like to then move on to our second objective, which is to help you better understand the pacemaker implant procedure. I'll start by describing to you the components of a permanent pacemaker system. This includes the pulse generator, which is shown in this picture on the slide, which includes a sensor for the heart's electrical signals, a generator that delivers electrical impulses that can then pace the heart as needed. It also includes a microprocessor and a battery. Now, this pulse generator, which effectively serves as the brain of the pacemaker, connects to your heart via these flexible leads, which are passed through, in most cases, the veins leading into the heart, and these leads then anchor into the muscle of the heart. There are different mechanisms by which these leads can anchor into the heart. In the case of the leads that are shown in this slide, there's a small corkscrew that is advanced into the muscle when the operator finds the optimal location for the lead in the heart. The next component of the pacemaker system is the patient care system, which is an external communicating device which communicates with this generator, which will sit under the skin of the patient in a wireless fashion. And this allows us to gather important diagnostic information from the device and also to perform quality control checks and also to check for any abnormal heart rhythms that may be continuing despite the presence of the pacemaker. And of course, the last component of the system, and certainly not the least, is the patient themselves. This is an X-ray that shows the location of a single chamber pacemaker in a patient. You see here the location of the pulse generator, which sits under the skin just over the left pectoral muscle. And you see the generator and the lead that is connected to it. The lead then is placed through the vein that courses underneath the clavicle here, and was then advanced down through the venous system into the heart. And here you see the tip of the lead resting in the apex of the right ventricle. There are several types of pacemakers, including the single chamber system that I showed you in the last slide, which paces and senses only in the ventricle. It is also common to see dual chamber pacemakers in which there is a lead not just in the ventricle, but also in the atrium. And this allows for synchronization of the contraction of the upper and lower chambers of the heart. This system has many features in common with the single chamber system, and it is implanted in the same fashion in the same location in most cases. So how is it that we go about a pacemaker implant? Well, this is a minimally invasive procedure which is performed in a procedural suite in a hospital. It's performed under conscious sedation, something that you might call a twilight sleep, or in some cases, people may need to be under general anesthesia. And the procedure is conducted in the following fashion. The operator will start by making an incision in the skin just below the collarbone, and will then make a pocket underneath the skin to accommodate the pulse generator. The operator will then gain access to the vein that courses underneath the collarbone and advance the leads down into the heart, anchor them in place, and ensure that all of the quality control checks that need to be performed are indeed performed and that the results are acceptable. Once the leads are deemed to be in an appropriate position, they are then hooked up to the pulse generator. The incision is then closed. And then it's common for patients to spend one night in the hospital to recover after the procedure, but same-day discharge is also possible. So what are the risks of pacemaker implant? It's possible anytime that we make an incision that we can cause bleeding. It's also possible that the implant site can become infected. As we gain access to the veins under the collarbone, it's possible that we can cause inadvertent damage to the underlying lung tissue. And when the leads are anchored into the heart, it's also possible that they can damage the walls of the heart, potentially even requiring another procedure to repair the damage. These are relatively rare events. Approximately 1% of cases have an incidence of bleeding or infection, damage to the lung, or damage to the heart. And there are also other types of pacemakers that I should tell you about that don't involve placement through the vein that courses underneath your collarbone. There's also a leadless pacemaker, which you may have all heard about already. This is a pacemaker in which all the components of the system are housed in a single capsule, which sits in the right ventricle, very close to the location where the tip of a lead of a standard pacemaker would go. This does not have the wires and may lead to a low risk of infection. The logistics of the implant procedure itself are comparable to that of implant of a standard pacemaker system in that it's performed in a procedural suite in the hospital. In many cases, people are admitted for one night to recover. And regarding the choice between implant of a leadless pacemaker versus a standard pacemaker with a pulse generator and leads, you should know that your physician will review your case and will tell you if this type of device is right for you versus a standard system. Now on to the last of our three objectives, which is to help you better understand what to expect after the pacemaker implant. So after you leave the hospital with a pacemaker, you will have a brief period of post-implant activity restrictions. And the purpose of these restrictions is the following. Until your body forms a scar envelope around the pulse generator, it will not be positionally stable. So if you engage in any exuberant physical movements, it's possible for the system to move inside of your body, potentially even pulling the wires back out of your heart, which is something we don't want to see happen to you. Therefore, your physician will ask you to not lift your elbow on the side of the pacemaker implant above shoulder height, and they will also ask you not to lift anything heavier than 2 kilograms or nearly 5 pounds. And this will be for the first 4 to 6 weeks after the device implant. In addition, you'll have to be careful to look after the implant site. In many cases, physicians will ask their patients to keep the site perfectly dry for at least 5 days after the implant. After the 5-day mark, you can get it wet in a shower, but you ought not submerge yourself in water until the incision is fully healed, and that'll take 4 to 6 weeks. So this wound care period coincides with the period of post-implant activity restrictions. Then at some point after that, you will have an appointment to see your cardiologist in the office, at which time they will inspect the site, make sure that all is well, and also perform a wireless check of your device using one of these additional programmer or interrogation devices. And this will, as I mentioned earlier, wirelessly communicate with the pulse generator that sits in your chest, or in the context of a leadless pacemaker, will communicate directly with the capsule that is sitting in the right ventricle. And this will be performed to perform basic integrity checks of the system, and also to monitor for any additional heart rhythms. And after that first visit, you will have ongoing visits with your cardiologist to make sure that the device continues to operate properly. And this will be some combination of in-person and remote checks. And the timing of these checks vary among practices. So just to summarize our 3 objectives for this session, first is to help you recognize the reasons for pacemaker implant. And I hope you understand now that pacemakers are implanted in those people who have cardiac conduction system issues that lead to slow heart rates. Second objective was to help you better understand the pacemaker implant procedure. And I hope you now understand that it's a minimally invasive procedure performed in the hospital, often but not always associated with one-night stay in the hospital. My last objective was to help you better understand what to expect after pacemaker implant. And I hope you now know that routine wireless checks of the device will happen throughout the life of the device for you. So thank you very much for your attention during this session. It was a pleasure to join you. And if you have any further questions about pacemaker implant or any other arrhythmia-related issue, I welcome you to look at the Heart Rhythm Alliance website. Thanks again for your attention.
Thank you, Dr. Chazcek, for a fantastic presentation there. Ahead of this recording, we've had a few questions that have been submitted by some of our patients. So if you don't mind, I'll jump right straight into them. Yeah, if you want me to repeat any of them, please do let me know. So one of the first questions that's been sent in is quite a comprehensive question. So the question is, since having my pacemaker, I've returned to my normal life, including back to running. However, sometimes when I'm running, I feel like I'm having palpitations. If I walk just for a few seconds, it stops. I've been advised my pacemaker is working, but my smartwatch will still record a low resting heart rate, 30 to 40 beats per minute, but was told this was because I was getting ectopic beats. Is this causing the palpitations?
The short answer is possibly. You should know that the manner in which you're checking your pulse at home will determine whether or not the reading you get is a true reflection of your heart rate. What I'm saying there is the following. Sometimes an extra beat in the heart that manifests as a different electrical impulse will lead to a disorganized contraction of the heart such that it doesn't produce a pulse. So if you're using a pulse oximeter, for example, that extra beat that happened in your heart that you can see electrically if you look at an EKG would not be present on your pulse, such that it would be +1 electrical, -1 plumbing, if you will. So it is possible that the discrepancy between the base rate at which your pacemaker is set and what you're reading at home is indeed due to these extra beats that are simply not leading to organized contractions. Whether or not that's related to the symptoms you're experiencing when you're running is a different matter. And the short answer there is that it's not necessarily correlated. There are several possible explanations for your sensations while running. You should know that pacemakers are equipped with a rate responsiveness feature, which allows the pacemaker to augment the heart rate in response to perceived exercise. And although this feature is intended to replace your body's own ability to increase or decrease heart rate in response to activity, it's not quite as good as what your body can produce. And you may notice that there's a slight mismatch between what you're doing and what your heart rate goes to. So for those people who experience very fast heart rates with a comparatively low level of activity, if it is indeed the case that their rate responsiveness feature is on, you may find that it's a bit too aggressive for you and it may need to be dialed back. It could also be possible that you're having palpitations which are the result of extra beats, which are more frequent with your exercise. The best way to determine which one of those things is really in play is to perform a device interrogation in your doctor's office, and they can then parse out which of these explanations is indeed responsible for your symptoms and make the appropriate changes in your settings. In rare circumstances, it could also be possible that intermittently slow heart rates perceived by the patient are indeed due to malfunction of the pacing system. And that's another thing that could be determined with an in-person interrogation of the system.
Fantastic. Thank you for that comprehensive answer then, Dr. Tashek. That was fantastic. So the next question is, I'm on the waiting list for a pace and a ablate and would like to know how effective the two are together.
The pace and ablate strategy can be performed in select circumstances. And without knowing more details about your care, I can't assume too much about what's happening, but one common circumstance in which a quote unquote pace and ablate strategy is performed is the following. In some patients with atrial fibrillation, they can have very fast heart rates that we simply can't bring down effectively with medications. And in some patients, even attempted ablation is not enough to keep the person in normal rhythm. In those cases, it's possible that persistently fast heart rates lead not only to symptoms, but possibly also to heart failure. So it's very important to manage the heart rates effectively. And sometimes when ablations and medications don't work, what we do is we implant a pacemaker and then ablate the junction between the atria and the ventricles, which under typical circumstances is the only electrical connection between the upper and lower chambers of the heart. And by ablating there, we effectively knock out your heart's metronome, if you will, such that you become dependent on the pacemaker. And this keeps the heart rates slower. And this is typically what I'll call a court of last resort. That is to say, a strategy that we perform only when aggressive medical and interventional strategies have not succeeded in either controlling heart rates in AFib or restoring normal rhythm. I hope that answers your question. I've done the best I could with the information provided. It is, of course, possible that your pace and ablate strategy refers to a different scenario. If yes, please feel free to contact us and I'll be happy to address the specific scenario in your case.
Fantastic. I think that's so important. If anyone has any further questions, please don't hesitate to contact that email address below, and we can really dive into kind of a bit more depth if needed. That's absolutely fine. So the next question is also in the subject. So the question is, I had a pacemaker implanted recently. As a healthy 61-year-old, I was shocked to find out that I needed one following episodes of dizziness. Are there other people out there like me?
Absolutely. It is very common for people to have disease of the heart's electrical conduction system in the absence of any other disease of the heart, such as coronary artery disease or heart failure. This type of degeneration of the conduction system is age-related. There may also be a genetic component to it. So the short answer is yes, it's quite common.
Fantastic. The next question is, I am experiencing sleep problems. I doze and awake mostly 5 times each night. Is this a result of having my pacemaker?
Not necessarily. Disordered sleep, as you report, is very commonly the result of sleep apnea. And I would recommend that you contact your primary care provider or your GP to consider being evaluated with a sleep study to see if you're having sleep apnea, which could be the explanation for your symptoms.
Fantastic. And just on to the final question, which is quite a long question. So if you need me to repeat it, Doctor, please do let me know. And it's quite medical, very impressed with some of the terminology here. So I am unable to have biventricular pacemaker fitted because of the anatomical anomaly PLSSVC. I had a single RV lead fitted in the septum recently, and I am now waiting for AV node ablation. I have been told that my left ventricle is healthy and that I shouldn't worry about cardiomyopathy in my left ventricle as a result of 100% pacing from the right ventricle. The cardio EP is happy to consider His bundle pacing if there is evidence of damage to my left ventricle. Any comments or thoughts on my situation would be very welcome.
Yes, so it is a well-known phenomenon that those patients who are paced in the ventricle 100% of the time or a large percentage of the time can develop a decrease in the pumping efficiency of the ventricles as a direct consequence of the pacing. And in those patients, synchronization of the ventricles can help. Now, there are several different strategies for that, including placement of a left ventricular pacing lead, or a His bundle lead, or left bundle pacing. At this point, it may not be necessary to proceed with addition of a lead to your system until such time as you demonstrate that the pumping function of your heart is indeed declining. It will be prudent, however, and of course your doctor will determine the appropriateness of this, to watch you closely to see if you develop any signs of decreased pumping efficiency of the left ventricle. And at that time, it may be appropriate to consider you for an upgrade of your system.
Fantastic. That's all the questions that we've had from our patients today. So on behalf of the Arrhythmia Alliance, AF Association and STARS, I'd like to thank you, Dr. Tashek, for your time today and your expert knowledge in this subject. So thank you very much.
I'm very happy to join you. Thank you.